Welcome back to the Deep Dive. Today, we're zeroing in on a set of critical sources for a very specific mission, helping you prepare for your high-stakes medical exams. We're going deep on the molecular backbone of modern anesthesia.
Exactly. If you're prepping for your MD anesthesiology exams, you know sevoflurane isn't just an agent, it's the workhorse.
Right.
And its pharmacology is a favorite for examiners, for long answers, and especially for the Viva. It forces you to connect chemistry, kinetics, dynamics, everything.
So what's the mission today?
Our mission is to build the perfect exam answer. We're going to structure this knowledge perfectly, section by section, hitting all 15 of those required elements for a top-scoring response. ##1. Introduction. Exam framing.
Okay, let's jump right in. The mandatory opening for any long answer. Definition and classification. So what is sevoflurane, chemically speaking?
Okay, first line of your answer. Sevoflurane is a polyfluorinated volatile anesthetic.
Polyfluorinated.
Right. And its chemical class is a fluorinated methyl isopropyl ether. But the real key, the thing you have to mention right away, is that it's halogenated solely with fluorine.
Just fluorine. Why is that so critical to point out?
Because that's what separates it from the older crowd. Isoflurane has chlorine, halothane had bromine and chlorine. That exclusive fluorination has huge implications for safety and metabolism, which we'll get into. Physically, it's simple. A clear, colorless, non-flammable liquid. Very straightforward.
So in the grand scheme of things, where does sevoflurane sit? We've come a long way from the old ethers.
It's really in a commanding position. People often describe its properties as somewhere between isoflurane and desflurane. It's a preferred modern agent for two big reasons. It's really low blood solubility, which is all about speed, and the fact that it's non-irritating.
And that non-irritating part is huge for mass conductions.
Huge. It lets us get away from the problems of the older agents, you know, the slow wake-ups with halothane or the kidney toxicity risks with methoxyflurane. Sevoflurane gives us speed and control.
Which brings us to why it's such a classic exam question. It's not just because it's used everywhere, is it?
That's part of it, for sure. It's indispensable, especially in pediatrics. But the deeper reason examiners love it is because it tests your ability to handle nuance and controversy.
The controversy being?
The whole debate around its metabolism. You have to be able to talk about the production of inorganic fluoride ions and the risks of something called compound A. Mastering SEVO means you've mastered both the clinical application and the critical safety science behind it. #2. Chemical and physical properties.
Okay, let's unpack that. Time for the high-yield numbers and the chemistry that drives its behavior. Starting with the structure, what's the key safety advantage it has over, say, halothane?
So, as a fluorinated methyl isopropyl ether, its structure is inherently stable in a very specific way. When it gets metabolized, it does not produce these things called trifluoroacetylated liver proteins.
And those are the bad guys.
Those are the bad guys. That's the mechanism that caused the rare but devastating immune-mediated hepatotoxicity, halothane hepatitis. Sevoflurane completely avoids that pathway. That's a massive safety point you have to make.
Got it. Okay, let's get into the numbers. These are the ones you just have to memorize. Let's start with volatility, the boiling point, and SVP.
Right. The boiling point is modest. It's 59 degrees Celsius. 58.5 if you want to be precise. 59 degrees. And that gives it a saturated vapor pressure, or SVP, of 157 millimeters of mercury. People often round that to 160.
And 157 is the magic number that lets us use a standard vaporizer, right? That's the clinical link.
That's the huge clinical link. Unlike desflurane, which boils near room temperature and needs a special heated, pressurized, very expensive vaporizer, sevoflurane works perfectly in a conventional, temperature-compensated, variable bypass vaporizer. It's simpler and cheaper.
That makes a massive difference in practice.
Yeah.
Okay, next up, the core determinant of speed, solubility. What are the partition coefficients we need to know?
Okay, number one is the blood-gas partition coefficient. This is your proxy for speed. Sevoflurane's is low. It's 0.65 to 0.69.
And for context, isoflurane is?
Isochlorine is 1.4. Halothane is 2.5. So you can see how much less soluble Sevo is. It's a little more soluble than desflurane, which is 0.42, but it's in that fast category.
Okay, and the other one, the oil-gas partition coefficient.
Right, that predicts potency. For Sevo, it's around 47 to 53. Again, right in the middle. Halothane is way up at 224. Desflurane is down at 19.
And that brings us to potency itself, the minimum alveolar concentration, or MA. What's the adult value, and what's the detail that'll make you stand out in the exam?
The standard adult MAC for a 40-year-old is 1.8 to 2.0%. You have to know that number.
1.8 to 2%.
But where you show your depth is by knowing it's highly age-dependent and actually peaks in infancy. For neonates, it's 3.3%. For infants age 1 to 6 months, it's 3.2%. Then it drops to 2.5% for children older than 6 months.
Wow, so a 5-month-old needs more than a 5-year-old.
Exactly. That's a classic exam trap. They'll probe you on that.
Okay, let's tie these numbers together. That low blood gas number, 0.65, what does that mean in the OR?
It means low blood solubility. So when you deliver the agent, the blood gets saturated really quickly because not much of it dissolves. This lets the pressure in your lungs rapidly match the pressure of the gas you're delivering.
Which means it gets to the brain faster.
Much faster. It means rapid induction and, just as importantly, rapid emergence. And because not much is stored in the body's tissues, the length of the surgery doesn't really affect the wake-up time. That's what we call a low context-sensitive half-time.
And the most obvious benefit, especially with kids, the smell.
Yes, its pleasant odor and non-irritancy are why it's the king of mask induction. It's not pungent like Isoflurane or Desflurane, which make you want to cough and hold your breath. With Sevo, it's just a smooth, easy drift off to sleep.
And briefly, that MAC and oil gas relationship.
It just confirms the general rule of thumb, the Meyer-Overton correlation. Lower MAC, meaning higher potency, generally corresponds to higher lipid solubility. Sevoflurane fits that pattern perfectly, sitting right in the middle of the pack. ###3. Mechanism of action.
So we know how fast it gets to the brain. Now, how does it actually, switch to brain off? What's the general mechanism for these volatile agents?
Well, the driving force is partial pressure. The pressure of the gas in the alveoli of the lungs determines the pressure in the blood, and that determines the pressure in the brain. And that brain concentration is what gives you the clinical effect.
But where's the site of action? I remember learning that immobility doesn't actually come from the cortex.
That's absolutely right, and it's a fantastic Viva question. Volatile anesthetics produce immobility, the thing that stops a patient from moving during surgery, primarily at the level of the spinal cord.
So MEC is really a spinal cord measure.
Fundamentally, yes. MEC is a measure of the suppression of the spinal nociceptive withdrawal reflex. The brain gets suppressed at lower concentrations, sure, but that state of true immobility is a spinal phenomenon.
Okay, focusing on Sevoflurane itself, what are its specific effects on the CNS? And which molecular targets are we talking about?
Systemically, it's a potent brain suppressor. It causes a big drop in the cerebral metabolic oxygen requirements, or CMR, sometimes by as much as 30 or 40%.
And on the molecular level?
At the molecular level, we think it works by modulating ion channels. Specifically, it seems to activate inhibitory channels, like the two pore domain potassium channels, one called TRK1 is a key player.
So it makes it harder for neurons to fire.
Exactly. It hyperpolarizes them. It also enhances the effect of the inhibitory neurotransmitter GABA. And on the flip side, it slightly inhibits some excitatory channels, like certain calcium channels. So it's dual effect. Boost the brakes and ease off the gas.
And a really important safety point, what about seizure activity? I know that was an issue with Enflurane.
A huge issue. But no, seizure activity has not been reported with Sevoflurane. It's much safer from that perspective, which is critical when CNS stability is a priority.
We've been using MA as our benchmark. In an exam, how should you talk about its relationship to the actual depth of anesthesia? Can you just rely on the MA value on the monitor?
That's the critical thinking question right there. The answer is absolutely not. MACE is the gold standard for comparing potency between drugs, but you can never rely on it alone for an individual patient.
Why not?
Because there's just too much individual variation. Plus, so many things can change a patient's MA. You have to be able to list them. Age, body temperature, other drugs on board like opioids or benzos. They all reduce MA.
So a MACE is a starting point, a guideline.
Exactly. You monitor depth holistically. You look at the MA value, yes, but also at the patient's clinical signs, maybe a processed EEG. And fundamentally, you're always watching for any response to surgical stimulation. MA is a guide, not a destination. #4 pharmacokinetics.
Okay, pharmacokinetics. What the body does to the drug. This is all about speed and control. You mentioned Sevoflurane's efficiency before. Let's dig into its uptake and distribution.
Indeed. The story is speed. That low blood gas coefficient of 0.65 means uptake is incredibly rapid. The ratio of the alveolar concentration to the inspired concentration, the FA over FI ratio, climbs very, very steeply.
So the lungs fill up fast and it quickly gets into the bloodstream.
Right. And from there, it's distributed based on blood flow. The vessel-rich organs, brain, heart, liver, get saturated first, but because it's not very soluble, the blood itself doesn't act like a big sponge, so the brain concentration rises very quickly.
Okay, for the exam, you need to list the factors that affect that FA-FI ratio.
Yeah.
Let's break it down. What speeds up the onset of anesthesia?
Right. Anything that increases the delivery of the agent or reduces its removal will speed it up. So number 1, a high inspired concentration. We call that the concentration effect. Number 2, increased minute ventilation, just breathing faster and deeper.
More gas in, faster onset. Makes sense.
And then there are things that slow it down, things that increase its removal from the lungs. The main one is high cardiac output.
Wait, a strong heart slows it down? That seems counterintuitive.
It does. But think of it this way. If blood is rushing through the lungs really fast, it acts like a conveyor belt, whisking the anesthetic away to the rest of the body before the alveolar partial pressure has a chance to build up. So a high cardiac output actually increases uptake from the lungs, which slows the rate of rise of the FA-FI ratio.
Got it. Okay, now for the really crucial safety part. Metabolism and elimination. This is where the controversy comes in. How much of it is actually metabolized?
Sevoflurane is metabolized more than its modern peers, about 2 to 5% of the absorbed dose. And the key enzyme you have to name is cytochrome P450 isoform 2E1, or CYP2E1.
And what does that breakdown produce?
2 main things: a non-volatile metabolite called hexafluoroisopropyl, or HFIP, and the one that everyone worries about, inorganic fluoride ions.
Right, the fluoride ions. So how does the body get rid of all this?
The vast majority of the drug, the 95 to 98% that isn't metabolized, is just exhaled through the lungs. The HFE metabolite is harmless. It gets conjugated in the liver and then safely excreted by the kidneys. But those fluoride ions are the focus of the debate.
Okay, let's tackle that head on. This is the core defense you need in the exam. Fluoride ions were linked to kidney failure with methoxyflurane. So why is sevoflurane safe?
This needs a very clear, structured answer.
Yeah.
Yes, plasma fluoride levels do rise after sevoflurane. They can average 20 to 30 micromoles, and in some patients, they can even briefly exceed the old nephrotoxic threshold of 50.
So it does cross that line.
It can, but, and this is the critical part, extensive clinical evidence confirms sevoflurane does not cause clinically significant kidney damage in humans.
The reason is?
There are a few key reasons, and you have to compare it to methoxyflurane. First, Sevo is cleared so quickly that the high fluoride levels are very brief. We're talking hours, not days. Methoxyflurane was really fatty. It hung around for a long time.
Okay, so duration of exposure matters.
It matters a lot. But the most vital point is where the metabolism happens. With sevoflurane, it's mostly in the liver. The fluoride is produced in the liver and then enters the general circulation. With methoxyflurane, a significant amount of metabolism happened inside the kidney itself.
So it was a local effect.
Exactly. It was that high local concentration of fluoride being produced right inside the renal tubules that was so toxic. Sevoflurane has minimal intrarenal metabolism, so even if the blood level peaks, the kidney itself is protected. That's the key distinction. #5. Pharmacodynamics, very high yield.
Okay, this next section, pharmacodynamics, what the drug does to the body, is where you can really rack up marks in a long answer. Let's start with the big one, cardiovascular effects.
Right. It's a dose-dependent cardiovascular depressant, and it does this in 2 main ways. First, it directly depresses myocardial contractility. It weakens the heart's pump.
Okay.
And second, it reduces systemic vascular resistance, or SVR. It relaxes the peripheral arteries. Both of those things together cause a drop in blood pressure.
Now, the heart rate response is a really key differentiator, isn't it?
It's a massive point of comparison. Sevoflurane causes little, if any, rise in heart rate. It's very stable in that regard.
Unlike isoflurane or desflurane.
Exactly. With those agents, if you crank up the concentration quickly, you often get this big reflex tachycardia. Sevoflurane avoids that, but it's a double-edged sword.
How so?
Because that tachycardia is a compensatory mechanism. With isoflurane, the heart rate goes up to help maintain cardiac output, even as the blood pressure drops. Since sevoflurane doesn't do that, its cardiac output is actually depressed a bit more. It's not maintained as well.
So in a sick patient, that could be a problem.
In a sick or volume-depleted patient, yes, the hypotension can be more pronounced. You also have to mention it's a coronary vasodilator and that there are some reports it can prolong the QT interval, though the clinical risk is very low.
Okay, let's move to the lungs. Respiratory effects. They're all depressants, but what are the specifics for sevoflurane?
It's the classic dose-dependent depression. You see a big drop in tidal volume, the size of each breath.
Right.
And you get a slight increase in respiratory rate, but that increase is nowhere near enough to make up for the smaller breaths. The net effect is a 30 to 50% drop in minute ventilation at 1 mSc.
And what does it do to our protective reflexes, like the drive to breathe when CO2 goes up?
It wipes them out. It profoundly depresses the ventilatory response to hypercapnia, and it pretty much abolishes the response to hypoxia. So once you get to 1 mSc, that patient is completely relying on you to manage their breathing.
But the big upside for the respiratory system is its effect on the airways themselves.
Yes. This is where it really shines. It's a very potent bronchodilator. It's great at reversing bronchospasm.
And because it's non-irritating?
It's clinically superior for patients with asthma or reactive airway disease. You can induce them smoothly without triggering a bronchospasm in the first place, and at the same time, you're delivering a therapeutic bronchodilating drug. It's a win-win.
Okay, cerebral effects. This is critical for neuroanesthesia.
Right. So as we said, it significantly decreases the cerebral metabolic rate, the CMR. That's generally neuroprotective. But the story with cerebral blood flow and intracranial pressure is a bit more complicated.
How so?
Well, Sevoflurane is an intrinsic cerebral vasodilator. It widens the blood vessels in the brain. At low doses, this effect is often canceled out by the drop in metabolism. But at higher concentrations, say above 1.5 ms, that vasodilation wins out.
And that leads to?
Slight increases in cerebral blood flow and, consequently, intracranial pressure or ICP. That's obviously a concern in a patient with a brain tumor or a head injury.
So how do you manage that?
You can manage it. We often use mild hyperventilation to lower the CO2, which causes vasoconstriction and counteracts the drug's effect. And honestly, the reason Sevoflurane is still so valued in neurosurgery is its rapid emergence. Being able to do a reliable neuro exam moments after the surgery ends is a huge advantage that often outweighs the manageable ICP concerns.
Okay, let's quickly round out the other organ systems: renal, hepatic, neuromuscular.
Good news here. Hepatic and renal blood flows are well preserved, at least up to 1 MAC. Neuromuscularly, it provides some muscle relaxation itself, and importantly, it potentiates non-depolarizing muscle relaxants like rocuronium, so you might need less of those drugs. And finally, it causes dose-dependent relaxation of the uterus, which you have to keep in mind during obstetric procedures. #, #Tech6. Compound A and renal considerations. Exam favorite.
All right, we've arrived at the section the examiners love the most, but one with all the controversy. Compound A. Let's start with the basic chemistry. What is it and how is it formed?
Okay, you have to be precise here. Compound A is chemically known as fluoromethyl 2-cricarbola-2-defluoro-1-trifluoromethyl vinyl ether.
You don't have to say that 3 times fast.
No, but you do need to know that its formation is not metabolic. It happens outside the body, in the breathing circuit. Sevoflurane is chemically unstable when it comes into contact with moist, strong bases.
And where would it find those?
In the CO2 absorbent, the older formulations of soda lime and particularly bear lime contain potassium hydroxide and sodium hydroxide. These are very strong bases. In that alkaline environment, the sevoflurane molecule degrades and eliminates hydrogen fluoride, forming this new molecule, compound A.
So the CO2 absorber itself is the catalyst. How does the choice of absorbent affect how much is produced?
2 things drive production. First, temperature. The absorption of CO2 is an exothermic reaction. It produces heat. The hotter the absorbent gets, the faster the degradation of sevoflurane.
Okay.
And second is the alkalinity. Absorbents with those strong bases, KOH and NaOH, are the worst offenders. This is why the technology has shifted. Modern absorbents like Amsorb are calcium-based. They don't have those strong bases, and they produce virtually no compound A. This has been a huge safety advance.
This all becomes a major issue with low-flow anesthesia. This is what led to the FDA warnings, right?
Exactly. The problem with low-flow or closed-circuit anesthesia is that you're rebreathing the gases. So if compound A is being produced, it can accumulate in the circuit. And early studies in rats showed that compound A was undeniably nephrotoxic. It damaged their kidneys.
So as a precaution, the FDA put out specific guidelines. What are they?
You have to memorize these for the exam. The FDA recommends a fresh gas flow, or FGF, of at least 1 liter per minute for up to 1 hour. But for any case longer than an hour, they recommend at least 2 liters per minute. The idea is to flush the circuit and prevent that accumulation.
What has the actual evidence in humans shown? Has this fear played out in reality?
And this is the confident, critical part of your answer. Despite the FDA warning and the rat data, the overwhelming clinical evidence in humans has shown no convincing proof of postoperative renal dysfunction.
Even in patients who already have kidney problems?
Even in those patients. Low-flow sevoflurane has been used for millions of hours, and the safety record is excellent. It seems humans are just far less susceptible to compound toxicity than rats. So the risk exists chemically, but it's been proven to be clinically insignificant, especially when you use modern absorbents. #7 clinical uses.
Okay, with all that complex safety pharmacology behind us, let's talk about where this drug really shines in day-to-day practice.
Its number one undisputed strength is inhalational induction.
Because of the smell and the speed.
Exactly. It's fast, you can have loss of the eyelash reflex in about a minute, and it's pleasant. We often use a high concentration, maybe 4 to 8% in a mix of nitrous oxide and oxygen, and patients just drift off smoothly.
And for maintenance of anesthesia.
It's a workhorse for maintenance. Inpatient, outpatient, you name it. That low solubility means you have incredible control. You can deepen or lighten the anesthetic level very quickly in response to what the surgeon is doing. That responsiveness is key.
You've mentioned pediatrics a few times. It really is the go-to agent for kids, isn't it?
It's the undisputed gold standard for mask induction in children. So many kids are scared of needles. Being able to just have them breathe a pleasant-smelling gas and fall asleep without any trauma is a game changer. It's just a much better experience for everyone involved.
What about for shorter cases? Daycare surgery.
It's great for that because of the rapid emergence. Patients wake up quickly, which helps with operating room turnover, but you have to add a little caveat in your exam answer.
Which is?
While they wake up fast, the actual discharge time from the recovery unit might not be any faster than with other agents, and that's because of the potential for emergence agitation, especially in kids. So they might be awake, but they're not ready to go home just yet. #8 dosage and administration.
All right, let's nail down the specifics of administration. What are the typical concentration ranges we're using?
So for induction, we hit it hard and fast. We use those higher concentrations in the 4 to 8% range to really drive it into the system quickly.
That's the concentration effect you mentioned.
Exactly. But for maintenance, once the patient is anesthetized, we can back off significantly. We typically aim for a concentration of around 1 to 2 AMAC. So for an adult, that might be somewhere between 1.8 to 4%, depending on whether we're using other drugs like opioids.
And you need more for a child.
Right, you have to adjust for their higher MA.
Can you just explain again why we need such a high concentration for induction compared to maintenance?
Sure. Think of the body as an empty bucket you're trying to fill. At the start of the case, the blood and tissues are sucking up the anesthetic like a sponge. You need that high inspired concentration to create a steep pressure gradient to force fill the brain and overcome that initial massive uptake by the rest of the body.
And once a bucket is full.
Once the vessel-rich organs are saturated, the rate of uptake slows way down. Then you only need a lower maintenance concentration just to replace what's being slowly absorbed by fat and what's being metabolized.
Okay, and let's quickly recap the main factors that would make you adjust that dose, the factors affecting NACE. Number 1 is age. MC is highest in incidence and goes down as you get older. Number 2 is other drugs. Opioids, benzos, nitrous oxide, they all have a synergistic effect and reduce the amount of Sevo you need.
That's the whole principle of balanced anesthesia.
That's it. Other things to remember are body temperature hypothermia decreases MA and surgical stimulation, which obviously increases the requirement. #tag99. Advantages of Sevoflurane. Okay, let's summarize. If you had to make the case for Sevoflurane, what are the top-line advantages you'd list?
The first, the absolute deal maker, is its non-pungent, pleasant odor. That's what makes stress-free mask induction possible, especially in kids.
And the second would have to be its speed.
Without a doubt, the rapid induction and emergence from that low blood gas coefficient. It gives you fast onset, great control, and quick recovery. It just makes the whole process more efficient.
We talked about its unique cardiac profile. How is that an advantage?
The hemodynamic stability, specifically the minimal effect on heart rate. It doesn't cause that big catecholamine surge or reflex tachycardia you can see with desflurane if you increase it too quickly. It provides a much smoother cardiovascular ride.
And all that adds up to its dominance in one area.
Yes, its overall pediatric acceptability. The combination of being non-irritating, fast-acting, and well-tolerated makes it the undisputed agent of choice for mask induction in that population. #10. Adverse effects and complications.
Of course, no drug is perfect. What are the main adverse effects and complications we need to be ready to manage?
First and foremost, hypotension. It's an expected, dose-dependent effect from the combination of myocardial depression and vasodilation. You have to watch for it and be ready to treat it.
And lungs.
Respiratory depression, again, dose-dependent. Reduced minute ventilation and a blunted response to CO2. This is why for most significant surgeries, controlled mechanical ventilation is mandatory.
You mentioned a specific post-op issue earlier, especially in kids.
Yes, emergence agitation. It's quite common. The child wakes up fast but can be restless, irritable, even inconsolable. It's often linked to pain, so good analgesia is key, but it's a real phenomenon that can delay discharge.
And then there's the big scary one that applies to all volatile agents.
That's malignant hyperthermia, or MH. Sevoflurane is a known trigger for this life-threatening genetic condition. It's rare, but you always have to have it in the back of your mind. A known susceptibility to MH is an absolute contraindication.
And finally, just to put a pin in it for the exam, how do we summarize the renal concerns?
You have to state the theoretical risk from the two pathways. Fluoride ions from metabolism and compound A from absorbent interaction. But then you must immediately follow up with the crucial context. These risks have not translated into clinically significant kidney damage in humans when modern practices are followed. #11, contraindications and precautions.
Okay, so what is the one absolute ironclad contraindication for using sevoflurane?
A known personal or family history of malignant hyperthermia, that's a hard stop for all volatile agents.
And what about the gray areas? What about using it in a patient who already has renal impairment?
This requires caution, but the evidence is actually very reassuring. Studies have shown that sevoflurane doesn't worsen pre-existing renal disease. Still, most of us would be prudent. For a long case in a patient with poor kidney function, you might choose to use higher fresh gas flows just to be extra safe and minimize any potential exposure time to metabolites.
And let's lock in the 3 key precautions for low-flow anesthesia to show you've mastered the compound A issue.
These are your safety protocols. 1. Follow the FGF guidelines, at least 2 liters per minute for cases longer than a MAC hour. 2. Avoid letting the absorbent canister get excessively hot. And 3, the most important one. Use a modern, calcium-based CO2 absorbent that doesn't contain the strong bases that create compound A in the first place.
Are there any other special patient populations where you need to be extra careful?
Yes, patients with severe cardiac disease, especially poor heart function. The dose-dependent myocardial depression needs to be titrated very carefully in them. And as we discussed, in neurosurgical patients with high ICP, you need to be cautious with concentrations above 1.5 mSc and be ready to manage it with hyperventilation. #12. Comparison with other volatile agents. This is a great section for the Viva. Examiners love comparison because it shows you don't just know facts, you understand clinical trade-offs.
Okay, let's do a head-to-head. Sevoflurane versus isoflurane.
Okay, for induction, there's no contest. Sevo is smooth and pleasant. Iso is pungent and irritant. Nobody uses iso for a mask induction. Kinetically, Sevo is much faster because it's less soluble. Its BG is 0.65 versus 1.4 for iso. Metabolically, Sevo is metabolized more, about 2 to 5% versus only 0.2% for iso. That's where the fluoride issue comes from. Cardiodynamically, Sevo keeps the heart rate stable, while iso often causes a reflex tachycardia that helps maintain cardiac output. And for toxicity, Sevo has the compound A risk, while iso has a specific risk of producing carbon monoxide if it interacts with dried out absorbent.
Got it. Now, what about compared to its older, pleasant-smelling cousin, sevoflurane versus halethane?
Again, they're both good for induction, but Sevo is way, way faster to wake up from because halethane is so much more soluble. Its BG is 2.5.
A huge difference.
Massive, and the safety profile is night and day. Halethane had that 20% metabolism rate and the risk of immune-mediated hepatitis. Sevo completely avoids that. And cardially, halethane sensitized the heart to catecholamines, making arrhythmia is a huge problem. That's not an issue with sevoflurane.
So what are the quick, punchy comparison points you need to have ready for the exam?
3 key things. 1, sevoflurane is the least pungent of the modern agents. 2, it's slightly more soluble than desflurane, meaning desflurane gives you the absolute fastest wake-up, though we're often only talking about a few minutes difference. And 3, it's metabolized way more than desflurane 5% versus 0.02%, which is why the fluoride and compound A discussions are specific to Sevo. #13, Viva points and common exam traps.
All right, final prep. Let's anticipate the Viva. What are the questions they're almost guaranteed to ask?
They love the basic kinetic questions. What are the 3 factors affecting anesthetic uptake?
You have to be ready.
Solubility, cardiac output, and the alveolo-venous partial pressure gradient.
Okay.
Another classic. Why is sevoflurane better than isoflurane for a mask induction? The answer is the combination of its non-pungent odor and its rapid onset from low solubility. And then the big safety one. Why is sevoflurane safe despite making fluoride? Your answer has to be about hepatic versus intrarenal metabolism and its rapid clearance.
Let's nail down that compound A answer one last time. How do you frame it professionally, balancing the fact versus the fear?
You have to be balanced. The fact is that compound A is a real chemical byproduct that is toxic to rat kidneys. The fear was that this would cause renal failure in humans.
And the reality.
The reality is that it hasn't. The safe, examiner-approved answer is to acknowledge the chemical risk, state the FDA guidelines as a prudent precaution, but then confidently present the overwhelming human evidence of clinical safety, especially with modern absorbents. The risk is manageable and, in practice, clinically insignificant.
And you mentioned a number-based trap earlier with kids.
Yes, that MC value discrepancy. They might ask why a 3-month-old needs more SIVO than a 3-year-old. Knowing that MC peaks in infancy at around 3.2% shows you've gone beyond just memorizing the adult value. It's a detail that separates the top candidates. Hashtag 14. Diagrams and exam presentation.
Okay, for the written paper, presentation matters. How can you use diagrams or structure to make a 20-mark answer really stand out?
Diagrams are a great way to show information efficiently. The most useful one is an FAI uptake curve. Just a quick sketch showing the steep, rapid rise of sevoflurane's curve approaching 1.0 compared to the slow, shallow curve of a high-solubility agent like halothane.
What about a chemical pathway?
Yes, a simple diagram of the metabolic pathway is high-scoring, just showing sevoflurane being broken down by CYP2E1 into HFIP and fluoride. And you could also mention how its moderate SVP allows it to be used in a conventional variable bypass vaporizer, which is a nice practical detail.
And for the overall structure of the answer.
Use the structure we followed today. Use all 15 headings, clearly underlined. This guarantees you've covered everything in a logical way, balancing the basic science, the pharmacology, and the clinical application.
Are there any specific headings that examiners will be looking for a lot of detail under?
Absolutely. They expect to see dedicated, detailed discussions under compound A, fluoride toxicity, and pediatric use. If you skimp on those 3 areas, you're leaving a lot of marks on the table. Hashtag 15, summary and exam conclusion.
That was an incredibly thorough breakdown. Let's do a final rapid-fire recap, the top take-home points for last-minute revision.
Okay, here's the high-yield checklist.
G is 0.65 to 0.69. That means fast on, fast off. 2, adult MAC is 1.8 to 2.0%. But remember, it's age-dependent. 3, it's non-pungent, the ideal agent for inhalational induction. 4, minimal effect on heart rate, so CO isn't as well maintained as with ISO or Didest. 5, metabolized 2 to 5% by CYP2E1, making fluoride an HFIP. 6, no immune-mediated hepatotoxicity, big safety win over halothane. 7, compound A is a chemical risk with old absorbents, but clinically insignificant now. 8, still, follow FGF precautions for low-flow cases. 9, it's a potent bronchodilator, great for asthmatics. 10, decreases CMR but can increase ICP at high doses, valued for rapid wake-ups in neuro. 11, it potentiates non-depolarizing muscle relaxants. 12, and it's a trigger for malignant hyperthermia.
That is the perfect checklist. So to finish off a long answer, what would be a model conclusion paragraph to leave a great final impression?
You want to summarize its overall place in modern anesthesia. Something like, sevoflurane is currently the agent of choice for inhalational induction and maintenance across all age groups due to its favorable solubility and non-irritancy. While it undergoes greater metabolism than its rivals, producing fluoride and compound A, extensive clinical data supports its safety, even in patients with renal dysfunction, provided modern low-flow precautions are followed. Its main limitations remain its cost and the potential for emergence agitation in children.
That is an authoritative and complete roadmap for the sevoflurane section of your exams. Thank you for guiding us through this incredibly detailed deep dive.
I hope this structured approach really helps with retention under pressure. But before we go, just one final thought for you to take away. We focused entirely on patient safety, but there's a growing conversation about the environmental impact of our anesthetic gases, their global warming potential. Comparing sevoflurane's environmental footprint to desflurane or isoflurane raises a whole new set of questions about the total cost of using this agent. That's a topic that's becoming more and more relevant, and something worth exploring on your own.